All right, so I want to make sure that we know RA versus OA, right? So RA is symmetrical, for instance, that it's a body-wide inflammation. It's not going to affect just the right knee, right? Whereas OA does, because it's due to wear and tear. Okay, so here's an example comparing RA versus OA, right? You got cartilage loss and all kinds of other, you got bone spurs, degenerated cartilage and such, whereas RA is the bone does get eroded, but it's really just severe inflammation, and then it has more and more deformity, and it's going to cause it's a number one arthritis that causes deformity. When we talk about gout, it causes your toe to be big and causes a deformity there. But this really causes deformities of the hands that are non-functional. They can't function anymore. Whereas OA, it's going to hurt, right? Is it going to hurt more during the day or less during the day, throughout the day? It's going to get worse throughout the day because they're grinding and grinding. If you imagine how it feels to grind things together, right? If we had chalk and a whiteboard, it feels like that, right? It's not going to feel great. Whereas RA is just inflammation, and it's going to get better throughout the day. It's like inflamed when they wake up in the morning, and then as you get throughout the day, then it starts to work better, right? Females are 3 times more likely than males to get it. Smoking puts you at risk. Viruses and bacteria put you at risk. But basically what triggers this, which on the next slide is some kind of, some kind of inflammation inside the joint, right? And smoking and viruses can put you into that piece, right? Patients may go into remission within a year of diagnosis, but usually patients need to have a prescription, just almost like HIV. They need to be on a regimen of drugs, right? And they call these drugs DMARDs, disease-modifying anti-rheumatic drugs. So they call them. So we have a slide on the drugs, right? So they have to be on these drugs because it's going to disease modify and it's going to prevent them from having deformities, right? So here's an example of deformities, right? You'll notice one joint area is not being manipulated. That's the distal interphalanges. That's one of the differences. Is dips are different, okay? Are not impacted by RA. Okay, so early diagnosis is important because they can then be starting the medications soon, and they can then stop the RA from getting out of hand. Because RA not only has joint issues like OA does, what OA does not have that RA has is extra articular symptoms. It affects everywhere in the body, not only just the joints, but affects the eyes, all the way down head to toe. Okay, so what happens? So you have an environmental something got in the way, and it's going to cause a inflammatory response inside the joints, right? And it caused normally you make collagen, right? The collagen is to make the bone matrix, and some of that might spill into the synovial fluid, right? But what happens here is something gets what's called citrulinated. Because it's citrullination of a collagen. So when you make a collagen, the recipe for collagen is like this many amino acids. Well, if you replace one of the amino acids, it becomes a different protein, right? And that different protein looks foreign to the body. What happens when there's a foreign protein anywhere in the body? Foreign antigen anywhere in the body? Your body is going to attack it, right? To cause an inflammatory response against a bacterial infection, a viral infection, and also something that is foreign. It thinks it's foreign, but you're the one that produced it. So since you produced it, you produce this different, this vimentin, right? It's a precursor to collagen. That vimentin looks different. It has a different amino acid, just like we're like Superman wearing glasses. Like, who are you? Or who the hell's that? Right? So it's still Superman, right? It's still Clark Kent. So I lost the analogy. Anyways, it's different. So then you start attacking it, right? Your body starts attacking it, and what attacks things are T cells, right? T cells attack things, and when it attacks those things, and it heats it up, and it presents the antigen over to the lymph nodes, and in the lymph nodes it says, hey, look what I found, and then the B cells make what? Make antibodies against this, right? So that's what happens. The B cells and T cells proliferate, right? And they actually play themselves. They start causing antibodies against that vimentin, right? Which is just like Clark Kent glasses, or just Superman glasses, right? So that's going to cause this widespread inflammation and attacking of our own cells. Yes?
Sorry, they said on Google we can't really hear you.
Oh, I forgot my mic. I left over here purposely so I don't confuse it. There we go. All right, can Zoom hear me now? All right, so that's the idea, is that we want to make sure that we are, or that's the idea, that's what happens. You're forming a immune response against this protein, and then you form antibodies against this protein. And then you form antibodies against this antibody against this protein, and that's called the rheumatic factor, right? So here's this IgM, this huge antibody you formed against this little protein right here that looks different, it just has glasses on, and then you formed an antibody against that. That's the rheumatic factor, which you can test on labs. That's why I bring it up, right? So the rheumatic factor can be assessed on labs, on diagnostic tests, and if they have the rheumatic factor present, that means they probably have rheumatoid arthritis, right? Because the rheumatoid factor is a conglomerate of things. It's an antibody against the protein that looks different. Okay, so how do you stop this? You stop B cells, you stop T cells, you stop B cells and T cells from even getting into the membrane itself, right? And that's going to hopefully be one of our medication strategies, right? Like losing weight, sure, whatever. It's not going to do this. This is an autoimmune process, right? You're forming this is a widespread inflammatory process that's causing not only joint damage, but extra joint damage, extra articular damage to the eyes, to the skin, and everywhere. Okay, so osteoclasts, it's widespread inflammation. Rank L gets stimulated, therefore you get bone erosion. Osteoclasts, you start cleaving bone, and now you're going to have bone-on-bone action, right? You get a swollen joint because whatever B cells and T cells do get in there are going to attack whatever that complex is, and they're going to start causing widespread inflammation. It's going to change the makeup. It's going to be very, very viscous and proteinaceous synovial fluid versus nice and thin, non-proteinaceous synovial fluid. So they're not going to walk good, right? It produces a pannus, not that one, but it produces a soft tissue formation over the bone joint, okay? And that's going to be a nice swollen joint, right? Produces less lube, right? There's always time for lube, but it causes this thick synovial fluid, right? And it causes cartilage breakdown. As we produce all of these different weird proteins, you're going to start causing inflammation against those things. And we talked about the rheumatic factor. It's an antibody against the protein that looks foreign, okay? And then you get a damaged joint. If you have a damaged joint, you're going to have more helpful B cells and T cells. Hey, you're inflamed? Let me help you out, right? Oh, what was that? Who's that, right? And then they're going to start causing more inflammation, okay? So we can help prevent B cells and T cells from getting into the joint in the first place by giving steroids. Steroids prevent the migration of white cells into tissues, right? And therefore reduce inflammation in the airways, for instance, for asthma, and what else we have in the spine. We're giving those intra-articular steroid injections, and also in the joints. Okay, what's going on? All right, so you got body-wide inflammation, right? And that's going to increase our ESR, right? Our erythrocyte sedimentation rate. So we have body-wide inflammation. Okay, so we have all these different things we just mentioned, and we're going to have high CRP. We have also, when you form that citrulinated protein, you can have an antibody against it. So that's the anti-CCP, all right? Citrulinated collagen, what does it stand for? I lost it. I thought I put it up there. Either way, there it is. It's in orange. Look at me. All right, so anti-CCP. That's what it stands for, but you just got to recognize you can see the antibody against that CCP, that protein, but also you have an antibody against that antibody and protein, which is the rheumatoid factor. Okay, you got the joint effusion, you got the boggy joint stiffness because you're going to start losing synovial fluid, and then you're going to have extra articular signs. Not only is it going to affect the joint, but it's going to affect everywhere through the body. All right, so symptoms. So it's symmetrical because why is it going to attack the right knee? What made it decide to attack that? It's going to attack both knees, both shoulders, both joints, right? But not the what? Not the dips, right? So there's no double dipping.
What are you doing? What? Did you just double dip that chip?
Excuse me?
You double dipped the chip.
Double dipped? What are you talking about?
You dipped the chip. You took a bite. And you dipped again.
So?
That's like putting your whole mouth right in the dip. Look, from now on, when you take a chip, just take one dip and end it.
Well, I'm sorry, Timmy. But I don't dip that way.
Oh, you don't, huh?
No. You dip the way you want to dip. I'll dip the way I want to dip.
Give me the chip!
Hey, get over here!
All right, so no dips, all right? So the small joints do get affected first, like the joints in the fingers, right? The large joints will be affected shortly thereafter. You can get redness around the area, warmth, and because of all that inflammation around the joint. And you get little nodules that can develop throughout the body as well. All right, so irreversible joint damage will occur with this. It's not like you can just turn it around. You have to start the medications early so you avoid this from happening in the first place, right? So you get this, what's called a swan neck deformity, right? You get hyperextension of the joint there, and you get a flexion of the other joint. All right, these are different finger symptoms that you might get, right? Ulnar deviation, right, is deviating going outward this way, right? They got morning stiffness again, but they get better throughout the day, right? If they hit rest, it's not going to improve their symptoms, right? So because it's a widespread inflammation, why would that help? Okay, and the key thing that's different from OA is that you have extra articular symptoms. You have symptoms that are not related to the joints, right? Whereas OA is just the joint. You don't start getting skin manifestations because you have osteoarthritis, right? Diagnostic tests they can be done, but they're not always there. So usually they have the symptoms, they got those nodes and such. It's affecting two joints on the same versus just affecting symmetrically versus asymmetrically. They can really say that they have rheumatoid arthritis. We have antibody against that weird protein, or we have antibody against that weird protein against that antibody. All right, that'd be the rheumatoid factor. They have inflammation that we mentioned, and they have anemia of chronic disease, which is like iron deficiency anemia, but it's widespread inflammation stimulating hepcidin, and hepcidin was what caused the lack of iron absorption in the intestines, right? And radiology, x-ray wise, there's certain x-ray findings. They'll see those specific joints that are inflamed and certain joints that are affected, okay? So that's the idea behind diagnostic tests. And the symptoms, again, are bilaterally, right? It's not just one side. It's going to be both sides, right? So you hear some nodules that are developing here, right? Not at the joint space, but in the skin, okay? What else do we have here? So they can do little arthrocenteses to help alleviate the problem there, but really it is this erosion that's going to cause more and more problems. So here's OA over here, and here's RA over here. Some more differences between them, right? Predisposing factors, obesity, right? It's a bone-on-bone action, right? It's a what's the word? A bone destruction problem with osteoarthritis, whereas RA is bone destruction, but it's due to inflammation. That's happening both sides, right? Who has a pannus? Well, technically both of them do, but the RA has a soft tissue over the joint, okay? So both of them have morning wood stiffness, but one of them gets better with movement, one of them does not, right? Which one gets better? RA gets better throughout the day, whereas OA gets worse throughout the day because they are grinding bone on bone, okay? And then treatment, NSAIDs, right? You might get some steroid injections, but with RA, you're gonna hit them up with the whole deluxe package, right? It's called disease-modifying anti-rheumatic drugs, okay? But before you get to the drugs, which I know you're looking forward to, that is we're gonna first start with the extra articular symptoms, so outside of the joint space. So it affects head to toe, everything, right? They're going to first have a surge response. They're going to be like febrile, have a white count elevation. SNS might be firing off, especially in an exacerbation of their RA, okay? And that usually happens with a virus infection, a recent virus infection. They'll get flu-like symptoms, and then every organ's affected. The eyes can get inflamed. The mouth can get, just like with methotrexate, right, can get inflamed. The lungs can get fibrosed, so now they have permanent lung disease. The heart can get pericarditis and restrictive cardiac disease, and then vessels can get inflamed, and it can cause and when it's inflamed, just like ASCVD causes you'd have a stroke and MI. Well, this is just inflammation that causes the same groundwork. right? Puts you at risk for a stroke and heart attack. Blood, we mentioned, muscles can atrophy, the bone can break down because you're stimulating all this bone breakdown from all this inflammation. And skin, you get permanent alopecia, ulcerative nodules, right? Livedo reticularis, which is like dead skin, the skin of dead bodies, right? So that's what their skin looks like at baseline, right? They get this dry mouth, which can lead to gingival disease, right? And then we mentioned the deformities that occur just from the joint itself, right? That you thought that was enough, but now the whole body is getting attacked, right? Also, the muscles are super weak. Also, the muscles in the neck can cause atlantoaxial subluxation. That's a fancy word for internal decapitation. So here's the spine, and there's the brain, or the skull. So it has subluxated, right? It has dislocated. So it can happen up there. It can happen anywhere, really.
Do they actually need to x-ray that?
Yeah, to figure out where to start. Okay, so it caused the subluxation of anything, really. Okay, so that's the idea behind the extra-articular symptoms for RA.
Hey, is this rheumatology? Yeah, what's going on? Are you ready for this? What? I've got a good one for you. If the ANA is positive in the absence of any relevant symptoms, then you C-ANCA positive, SCL70 antibody positive, anti-Jo1 antibody positive. What? I told you. Do they have a non-blanching rash? You better believe they do. Where's the rash? Forehead and the back of the hands. Fascinating. So it could be a crossover autoimmune vasculitis. Do they have an extensive family history of vasculitis? You bet they do. Kidney function? It's declining. Fever? Of course. Biopsy? Kidney, skin, muscle, all completed. It's perfect. The pathology report just says to have the rheumatologist call them. What's the extension? Well, do you have any idea what it is? Well, I've got about 17 potential diagnoses in mind, but it's much too early to say. Oh, okay. So I guess any treatment recommendations are going to have to wait until... Steroids. What? High-dose IV steroids. But I thought you said... I'll leave a very thorough and wordy assessment in my note after I speak with the pathologist. I probably won't be able to understand it. Agreed. Extension is 5454. Thank you for the interesting consult. You really mean that, don't you?
So really, any anti-inflammatory disease, the answer is steroids. That's going to stop the inflammation. It stops the B cells from producing antibodies, stops the white cells from going into the tissue causing the inflammation in the first place. So it's a great answer, right? And rheumatologists are just as bad as hematologists. They have many rare diseases they know about, and they don't label them anything that we can understand, right? And the tests are just as complicated. Okay, so the treatment. So again, we do disease-modifying anti-rheumatic drugs, right? And again, if someone has a flare-up of the RA, we give steroids, right? Steroids is really every autoimmune condition that's going to help stop it from progressing, right? Stops the WBCs from going to the joints, stops the B cells from releasing their antibodies, stops the T cells from attacking the things inside the joint, right? So we could do joint mobility and those things to decrease inflammation, but it's not really going to fix the underlying problem. It might help a little bit with excess inflammation, but even surgery, replacing the joint is not going to fix the underlying problem. They're just going to attack it again, right? So we have to give them pharmacological treatment. We have to give them meds, right? And it's to reduce deformities, reduce joint destruction. And basically, a lot of these meds are teratogenic. What does teratogenic mean? It stops the generation of teratogens. What's a teratogen? An alien, all right? Generates something that is not of this terra, of this earth, right? So it stops alien production, or birth defects is more politically correct way to say it. So we have they are usually all teratogens, right? So we're going to make sure they're not pregnant while they're on RA therapy. Right, we're going to make sure they don't get anemic, make sure they don't get bone marrow suppression. We're going to make sure they don't get renal dysfunction, liver dysfunction, and we're going to test them for all the possible opportunistic infections, things that could take hold, right? Because a lot of our DMARDs are also monoclonal antibodies that will stop B cells and stop T cells. If you're stopping B cells and T cells, now you're at risk for infection, right? The vaccinations must be up to date, and then we can start them on disease-modifying anti-rheumatic drugs, or DMARDs. So DMARDs used to be the only thing when I was in school, and now they've added biological DMARDs, which is where you have all kinds of fancy different drugs that, again, were designed by hematologists that nobody can understand, because it wasn't until 2019 where they decided you guys are out of control. We are going to have now a list of how to name these drugs, these monoclonal antibodies, right? They finally came up with a naming system in 2019. Before, they just got like the 5 guys in the room and their initials, and they then ended and slapped MAB at the end of it. So tocilizumab was like, you know, Tosker and Liz and, you know, and Zenny, and they all got together and said, let's call it tocilizumab. It's like, oh, cool, and they high-fived each other, and nobody else could understand how this drug worked, right? The only common thread is that MAB is a monoclonal antibody, and as an antibody, it's designed in the lab to go ahead and attack one specific thing. So like rituximab attacks B cells, the B cell receptors, right? So B cells over here is a B cell, right? So rituximab is going to inhibit that B cell directly, it shuts it down, right? So that's great. You're gonna shut down the B cell. The B cell is what makes the rheumatoid factor. It's what makes the other antibody against CCP. So it's gonna shut it down. It's gonna shut down the RA progression, right? So that's a medication they could get. They can get another medication that stops the inflammatory process, right? So we have TNF alpha. Remember all the different little cytokines, leukotrienes we talked about, right? Tumor necrosis. Is it tumor necrosis? Yeah, tumor necrosis factor alpha, I think. Either way, it's going to stop these little cytokines from causing the inflammatory cascade, right? And some of them are blocking different processes in the whole inflammatory process, and that will then lead to a risk of infection, right? All biologics have a risk for infection. So we don't do these biologic medications until they've kind of failed the first round, which is your DMARDs, right? So you have synthetic ones and biologic ones. The synthetic ones, methotrexate is our bread and butter for DMARDs, right? And we know methotrexate, right? Methotrexate is one of our chemo drugs, but it's also a medication we give PO to patients with RA, right? And how do you give that? It's PO weekly. So.
Look around, look at where you are, look at where you started. The fact that you're alive is a miracle. Just stay alive, that would be enough.
All right, so yeah, you don't want to take it daily. They were going to take a weekly dose of their methotrexate. The same side effects, right? It's hepatotoxic, it's causing ulceration of the mouth, right? So that's a complication of methotrexate. And then sulfasalazine is from one of our IBD meds, right? That's one of our for ulcerative colitis, right? Same thing. It's stopping. It's for pain, right? Hydroxychloroquine got a lot of attention with COVID, right? Everyone was taking HCQ. Every single person was taking that. They're thinking that it would stop COVID. And yes, it's anti-inflammatory, but it doesn't work for the viral piece. It works for this immune response. It kind of blocks the receptor sites for antigen-presenting cells, right? So once your body has chewed up something and grabbed the antigen, it presents it to B cells and T cells. Hydroxychloroquine stops that process, so it shuts down inflammation, okay? And then we have a few other, this is the only PO antibiologic we give that doesn't require, it's kind of an older drug that kind of gets grouped together with our other DMARDs, okay? So yeah, so DMARDs are preventing what? Preventing deformity, preventing progression of RA.